is a senior research fellow at the International Food Research Institute and is based in New Delhi. She is the team leader for Southeast Asia Nutrition Program in IFPRI's Poverty, Health and Nutrition Division. In her work in India, Dr. Menon directs POSHAN, that is Partnership and Opportunities to Strengthen and Harmonize Action in the Nutrition in India. It is an initiative to support more use of evidences for nutrition in India. She conducts implementation research on scaling up maternal and child nutrition interventions, including evaluating large-scale behavioral change and communication programs for nutrition and health. Dr. Menon has research experience in India, Bangladesh, Ethiopia, Haiti, Vietnam, and Nepal. She has published extensively and invests deeply in research translation in her engagements. She serves on several national and global advisory groups, including State of World's Children, Global Nutrition Report, and the Countdown to 2030. Dr. Menon has PhD in International Nutrition from Cornell University and an MSc in Nutrition from University in Delhi. I extend my warm welcome to our esteemed speaker, Dr. Purnima Menon ma'am. A kind request to all delegates to please post your queries in the chat box. Madam will be addressing those questions towards the end of session. May I now request Dr. Menon to kindly enlighten the audience and take the segment forward. Over to you, ma'am.
Well, thank you all so much for the opportunity to be here today. As Dr. Neha mentioned, one of the things that I value tremendously about my job is being able to share the research and insights that we are gaining with other partners. What I'll do today is actually not so much. I'll speak about POSHAN Abhiyaan, but I'll do it in a way that I think we try to reflect on it as we move through the presentation. But what I would really like to do is to start at the beginning, in a sense. And so, my the first things that I want to share are coming from the global literature. But I think it would be interesting. I'm guessing most of you here are medical professionals, and I can't see the chat box, but I'm going to ask a question first and ask for a few people to put a few numbers in the chat box. Okay. So my first question, and maybe it's the only one that's really important for an audience that is very health focused. What proportion of mothers and babies in India die with malnutrition as an underlying cause? What percentage of deaths of children under 5, let's just use that demographic, are because they are malnourished? If people would just like to put some numbers in the group, because thank you, Niveda, 10%. Somebody else would like 40%. Okay. Let's get at least maybe 5 numbers in. Okay. Because you can always Google it. So let's get 5. Okay, 35. All right. Okay. So I don't know who the last person is, Praveen, but you are getting close. It turns out, from estimates of research done by ICMR together with the Global Burden of Disease collaborators at the Institute for Health Metrics and Evaluation, the estimates are that almost 70%, so 68% of child deaths in India are attributable to malnutrition as an underlying cause. And so, I think to me, that's a number that any health professional should carry in their heads. It doesn't matter where you're working, whether you're in private sector, public sector, in health systems research, or researcher or practitioner in the policy community, advising policymakers, etc. But if you care about saving the lives of mothers and babies, you must care about malnutrition. So, really, if there's one thing you take away from my talk today, that I think can be it. Unfortunately, our successes, as Dr. Neha mentioned, have been slow, although there are successes, and I'll come to that in a little bit, because I think we speak a lot about problems when we speak about malnutrition, but there have been successes, and we learn a lot from that. I had the privilege of being a co-author on the recent Lancet Nutrition series that just came out in March 2021. Papers in the series. I was co-author on both of the papers. The first paper is on progress, and the second paper is on what can we learn about intervention. So I want to share a little bit about that because I think it sets the context. Um, and so the first paper, which was led by Cesar Victoria from Brazil, in that first paper, we show that there has been limited and uneven progress across the world. And I think even for India, this is true. We should think much more about how the progress within India has been uneven, and not that the progress itself has been limited. Our progress here in India has been limited because it has been uneven, because the states that carry the largest burdens of undernutrition have not progressed as fast as many of the other states in India. And there is a high burden of wasting in South Asia. We can speak a little bit more about the drivers of that later on, perhaps. And we, another sort of key piece that we emphasized in that paper, which is very, very pertinent to India, which is that social inequalities are the major distal determinants of the burden of maternal and child undernutrition. And the primary, uh, takeaway from that is that we need broad, multi-sectoral, strongly anti-poverty focused initiatives. And I really say to people, you cannot solve malnutrition with a nutrition program alone. You really need to address the social determinants. And so we'll reflect on that today as well. And of course, we are in the middle of a terrible pandemic, and this is a particularly bad time for India in terms of the health consequences. But the consequences of the pandemic will be far-reaching and have already had impacts on poverty and food insecurity. And so that just means that we really need to ramp up even more in terms of tackling the malnutrition challenge. Um, the second paper that we did in the Lancet updates the evidence on nutrition interventions. And in a previous series we had talked about 10 essential interventions, and in this series we referred to it as the 11 samurai. But more than the specific interventions, and the science behind those, I want to assure you that in fact, when you look at the POSHAN Abhiyaan intervention framework and India's policy framework and all of that, you have quite a few of these interventions are absolutely in the policy frameworks. What is most important is the figure on your right side, which is really that there are tremendous gaps in the delivery of these interventions. So our problem is not the science of discovery. Our problem is the science of delivery in ways that preserve the quality of interventions and that ensure equitable reach. And what you see, for example, is if you look just at the pregnancy platform, um, globally, you have 60% of the population, between 60 and 70% of pregnant women receive for antenatal care, but only 50% of them actually receive iron folic acid. And I think if you looked at the nutrition related interventions that are in any of these platforms of care, be they antenatal care or preventive child health, the challenge even today, and in India, and we have another paper that's been published on this, is that gap, what we are calling an opportunity gap, is not being closed. So that's really critical. And I think, again, for people working in health systems, this is how you can really help nutrition, is by taking a look at your platforms and saying, can we at least make sure that the basics that are supposed to happen for nutrition there happen? Now, one of the other things that we did in the Lancet, and I'll speak about this a little bit more, is, in addition to sort of identifying the science-based, efficacy-based effective interventions, we also invested in summarizing evidence from a whole set of recent studies on evidence for success at scale. So these are real-world exemplars and examples of countries across the world and Indian states. We had 4 Indian states that my research team has been studying for a long time now, where we showed what kinds of factors contribute to success. And here again, the social determinant story that we reflected on in paper 1 has become very important. We showed that in indirect actions that target underlying determinants such as poverty, wash, parental education account for almost 50% of the reduction that we see in stunting, and that some key factors that really need to be poverty alleviation, gender, and other such things. Investing in data to help us see where we are missing people, where we are missing, where those opportunity gaps in systems for delivery are coming, and then really sort of paying attention to not just what happens, in cross-sectoral meetings, etc., but are we really reaching the last mile and being coherent in the planning and the action? Now, in the work that we did from the Indian states, so we studied 4 states that had reduced childhood stunting more than the national average between 2006 and 16. We studied Chhattisgarh, Gujarat, Tamil Nadu, and Orissa. And here again, the multi-sectoral story comes out. So health and nutrition interventions and WASH together contributed to about 1/3 of the stunting reduction that we saw across these states. Maternal characteristics contributed about 1/3 of change, often more than 1/3 of change, which really relates to sort of both the biological and social antecedents of malnutrition in India, very much related to the status and health of girls and women. And last but not least, household assets and socioeconomic status accounted for another 30% of change. What we found across all of these states in terms of how policies and programs evolved is that, firstly, there were major national efforts in that 10-year period. That is the 10-year period when ICDS scaled up, not because anyone decided that that program was important to implement, but because the legal mandates in the right to food forced the universalization of ICDS. And then the NRHM was introduced, and an entire cadre of health workers was put on the ground over that 10-year period between 2006 and 16 that had major impacts on access to maternal and child care. In addition, though, the successful states, all of these successful states actually added to the national efforts and did so in ways that that varied. Some added more, some added less. Some got into the game early, like Orissa was already in the game and came much further than, for example, Gujarat, which really launched their state nutrition mission only in 2012. But all of these states also had accompanying investments in food security and poverty programs and/or economic growth. The policy change was supported by a vision, actually very strong signals that capable and stable bureaucrats were appointed to lead these otherwise neglected agendas, and those bureaucrats were given both political space and time to achieve the kinds of impacts that they did in the end. And there were lots of systems efforts to actually strengthen implementation. A lot of people also came together, so it wasn't just the government, but catalyst champions of various types. But again, it was a very, very good reminder that improving nutrition is going to take way more than ICDS. It's going to take way more than a nutrition program. And if I were to link this with what is happening within POSHAN Abhiyaan today, POSHAN Abhiyaan has acknowledged the importance of other sectors, has acknowledged the impact, the relevance of sectors such as WASH, but is still not doing enough in terms of really linking with a poverty alleviation agenda and with really focusing on addressing issues related to girls and women. Now I'll come back to this framework in the end. Okay. So now the last thing we did in the Lancet series is sort of propose a new framework based on all of this evidence, a new conceptual framework for us to think about how we tackle malnutrition, right? So mostly we think about these programs that are direct health sector, health, and I mean in India, ICDS to me is part of the health sector because it's working very closely with the health sector. But we must also think about indirect health sector interventions such as family planning and all of the work that many of you do on disease prevention and management. We must think about direct actions in other sectors such as fortification, mass media work, policies to protect breastfeeding, promotion of healthy diets, etc. And then the other sectoral strategies that relate to food security, poverty, WASH, empowerment, etc. I'll come back to just frame where we are on India and POSHAN Abhiyaan against this evidence-based framework when I end. So let's now look at what, with that background in mind, what do things look like today in India? Okay. So as Neha mentioned, progress on child anthropometric outcomes has slowed down between the 2016 and 19 period, but there are promising improvements in several different states. So for example, if you look at stunting, which is, just a summary in the green box here, actually, most of these slides are available on our website, by the way, so I'll share that in the chat box later. But we've seen in 10 of 20 states sort of slight increases. We've seen increases in 4 of 20 states. We've seen a decrease in stunting. And what's really interesting and useful is that in a state which has, probably one of the largest birth cohorts in India, like Bihar, they're seeing, some of the highest declines in stunting, which is very good for the national level figures. We need to see change in UP, in Bihar, in Maharashtra, Madhya Pradesh. These are the 4 largest states in India where most of the children are born every year in India. And so you really can't improve nutrition by just improving it at a national level, by just improving in Orissa or Tamil Nadu or Kerala or any other states. Things have to improve in the biggest states, for things to progress. On wasting, things were not so promising, but again, it was a bit of a mixed picture, an increase in some states, a decrease in some states. Wasting is hard to interpret with national surveys because what we have seen is that in the same state, the survey may be done at 2 completely different periods of time, and wasting is a very seasonal, has a strong seasonality to it, so that has to be accounted for. And so we're in the process of doing some analysis to look at that. Now, the last part, which is this part in red, is also important here because overweight has increased across the board in all states almost in India, has not really decreased in any states, and one has seen increases in overweight, not just for women, but for children, for adults, for adolescents. And so that's a big aspect of nutrition, again, that we need to really keep our eyes on. When we do these kinds of analyses, we use the cutoffs, we use, words such as stunting and wasting, but those are just based on, the cutoff of -2 standard deviations below the reference median. But what's really critical for us to keep our eyes on is the population. And one of the key points we try to make in the Lancet series, and, we'll be doing some more work on this one once the unit level data is out from NFHS, is that the distributional shift, so the shift in hyper-8 Z-score distribution, has been very slow to progress. So this is the WHO standard, right? It has a median of 0, and it's normally distributed with a standard deviation, of 1 around that. But across the world, low-income countries are moving very slowly towards that optimal distribution. And that's what we want to see. You can see that the middle-income countries, which are in the dotted lines, have, their curves have shifted quite a bit more over time. But in the low-income countries, the median in low-income countries, the mean of the distribution, sorry, not the median, is still around -2, and that's really problematic. That means that the entire population is malnourished, not just, those who are classified as stunted or wasted. Now, as I mentioned earlier, a lot of the work that we've been doing has been on understanding the drivers of malnutrition. And so I just want to share with you how have some known causes changed, and remind us that social inequalities remain the most prominent causes. And if we want to change, how children grow, which is what we're measuring when we measure stunting and wasting, we really have to pay attention to the social determinants of health, not just, the sort of what seem like tech or easy fixes within systems. And what we've seen is that, on one of the key determinants of malnutrition, of course, is how children and babies are fed. And there, the red box on the side there shows you that actually in most of the states, the timely introduction of complementary foods has actually gone down, even though breastfeeding has gone up. So we see really a mixed picture. I'll speed up a little bit because all of these slides are available. On the underlying determinants, again, like I said earlier, social determinants are really, really important. There's been a lot of progress on sanitation. This likely is because of the National Sanitation Mission, which started early, but there has been a very small change, even though it's a positive trend, on maternal well-being indicators. So, really solving these issues is a big one. Program coverage has generally improved over time. We have seen, for example, improvements in reach of antenatal care, reach of, different components of antenatal care, but the nutrition coverage within those has not progressed as fast. So you're not reaching very high levels of coverage yet of the nutrition interventions. So these are all interventions that are in POSHAN Abhiyaan's framework, but they need to move much faster so that all of these bars actually get to the 100%. And you see the same for um, the child health interventions as well. So overall, in terms of what we know needs to happen, the findings on nutrition suggest that what has happened in terms of change in India is necessary but not sufficient, and we need to make a lot more progress on solving the underlying, social determinants that lie in the gender space, and we need to do a lot more within existing health systems to make sure that the interventions that are in the policy framework are actually delivered with equity and with quality. Now, the under 5 children of NFHS 5 were born between 2014 and 19, and the National Nutrition Mission was launched only in March 2018. And so when we interpret what is happening for nutrition, we have to interpret it in sort of the fullness of that continuum of what happened. So this is my last slide. I'll stop here. This is the same Lancet framework that I mentioned. And what I've done is just sort of share, put in that what is already included in the policy frameworks in India for nutrition and what's missing. And so what's missing is the stuff that is flagged in red. So we need to do a lot more coupling with poverty alleviation work and do a lot more work on some of the underlying determinants related to gender and related to supporting other such foods. So let me stop there.
Sure, ma'am. Thank you for your kind words of wisdom. The data that you have shared is really very interesting, and I can see there are many people who are very excited to have answers for their queries. So, one of the questions that has been posed is years and years after the National Family Health Surveys are showing malnutrition is still existing or is much prevalent. So, do you think POSHAN Abhiyaan can make a dent in the prevalence of malnutrition and anemia in the pregnant women?
Yeah, I do think it can, and I say that because I think for the first time we have a very ambitious national framework. But I think what we're seeing in NFHS 5 in particular is a reminder that solving malnutrition takes more than a nutrition program, right? I mean, if there have been economic challenges in the last 5 years, or if things haven't improved on the social determinants, then those have to come under the ambit of the national program. We cannot just say, oh, we'll do something in ICDS and it's going to solve a problem that actually also has social and economic underpinnings. And so the challenge here is going to be to really understand, which parts of the country, which pockets or which districts need sort of this, the full multi-sectoral component of POSHAN Abhiyaan to kind of come together very fully. So, so I do think it's not a question of throwing away POSHAN Abhiyaan or throwing away any components of it, but it's about saying, how do you make the missing components work much better?
Absolutely correct. So, can you throw some light on the Anganwadi level infrastructure that has been a part of POSHAN Abhiyaan and how best it can augment it?
So, I think in rural areas in particular, the Anganwadis have a very important role to play. And we know that they are playing it because people are using it a lot, particularly in rural areas. And so, absolutely one has to really improve and strengthen completely, we have to build these centers and the programs and the services that are offered there as if any one of us would be willing and able to use those services, right? To me, that is what equity is. Somebody, Joy Lawn, who works a lot on maternal and child equity, says this. She said, your lens on high quality healthcare should be, would the wife of the president give birth in that center, in a rural health center? Okay. If your rural health centers are not set up in a way that anybody in your country, rich or poor, would get the same kind of experience, then you're very far away from equity. And I think that's what we know in India. There's a lot of work that happens in public policy that does not set up services for the poor the same way that services are available for people with more resources. And that tells you that at a planning level itself, we have possibly lost what equity should mean. Okay. So I think we need to think about Anganwadi centers in rural areas, Anganwadi centers, and any and all health centers across the country with a lens that says that I will use that service. I'm going to set it up. The person who's setting it up or designing it in an air-conditioned office somewhere usually should be setting things up with the lens that they will send their children to those schools. They will send their children to those preschools, those Anganwadi centers. If we are not going to design with those principles and values in mind, we are not going to get very far.
Absolutely correct, ma'am. Ma'am, one last question for the session. Can you elaborate something about the district level help desk under the POSHAN Abhiyaan?
Absolutely, sure. So one of the key components of POSHAN Abhiyaan is the technology component of it, and actually our team has been part of studying the technology component of it as well. And one of the things that we've learned with technology is when you're scaling up technology to that level, getting phones out to so many Anganwadi workers, to their supervisors, and to other people, the help desks have played a very critical function in hand-holding and solving problems at one hand. But the other thing that district help desks have done, which we learned in our research, is that for the district program officers and people in the district offices, also the people who manage the district help desk have also been the ones who've been pulling out the data from the dashboards and sharing it with DPOs and other such people for them to see what the services look like. So in that sense, the help desk staff for the technology component of the program have played a really important role.
It was indeed pleasure, ma'am, to hear you. Thank you so much.